Hello everyone, welcome to Inspire IMG. Inspire IMG is a global community for global opportunities. I'm very proud to introduce our guest speaker for today, Dr. Pragnesh Bhatt. He's a consultant neurosurgeon joining us from the UK. There is a lot to tell about him. I think this session may also not be enough. So you can see briefly a lot of hats that he's wearing currently. So we met Dr. Pragnesh Bhatt in RCS conference at RCS ED conference at Chennai. He was one of the kindest people we met. He gave us few minutes of his, though he was busy, he gave us few minutes of his time and allowed us to explain about Inspire IMG, our vision, and how this platform will help thousands of medical graduates exploring global career opportunities. We definitely need more such people like Dr. Pragnesh Bhatt who can come forward to help aspiring and young doctors who are exploring global opportunities. A very warm welcome to you, Doctor, and thank you so much for this time.
Thank you for the general introduction. May I share my slides, please?
Yes, Doctor, please. This is for the audience. Is the audio and video clear? Oh, thank you. Yes, Doctor. They all. Kanika, you're able to see Doctor's slides?
Yes, ma'am, I can see.
Okay. Dr. Anushka, thank you. She says yes, it is clear and visible. So we can go ahead, Doctor.
So thank you very much for giving me this opportunity. I want this to be not a didactic lecture. I am hoping that we'll generate enough interest so there will be some interaction and question answer. But if we could leave those till last, that may serve some purpose. So I am going to take next 40-45 minutes to explain three parts. One, what is it to be a neurosurgeon? That's part one. Then part two will be how one can be a neurosurgeon in UK. And third part is mainly philosophy surrounding my practice for more than 4 decades. So the first thing I would start with is the logo from my medical school in Baroda, which says Natvaham kamaye rajyam na swargam na punarbhavam kamaye duktatpanam praninam artinasanam. What it means is that we choose the medical career not for only our material pleasure, but we want to serve the humanity. And I will try to bring this thread all along my presentation. I don't know any of you are familiar with this picture or this saying, which Isaac Newton said, that if I have seen further than others, it is by standing upon the shoulder of giants. And I would like to bring some memories back of the people who have inspired me. Some of you may be knowing this person is Professor Harvey Cushing, the father of modern neurosurgery. He has many innovations to his credit. The next person is Sir Walter Dandy. He was another giant neurosurgeon, junior to Harvey Cushing, but has again innovated a lot. Then I bring my own professor in Mumbai, Professor Sanat Bhagwati, a giant of neurosurgery in India, but more importantly, a magnanimous human being. And last but not the least, the person who trained me in the UK, who is still practicing at the age of 75, Professor Guru Singhe, and he was just honored with a big award known as MBE in the UK this January. So having learnt a lot from these giants, I am going to share what I need to. Am I audible and visible, and are slides visible properly?
Yes, doctor. It's visible and it's clear.
Thank you. So now coming to the proper presentation, I am going to share some of the quotes that why one would be a neurosurgeon or what is so interesting of neurosurgery. Some people say it is a unique combination of perfect science and art, and we'll come back to that little later. Then some people say that they wanted to play with sophisticated toys because we have lots of gadgets in modern neurosurgery as compared to when I started. When I started, of course, it was very young and evolving specialty. And then in my own understanding, the clinical practice is most interesting, and I will come back to that little later when I quote Sir William Osler. And the operating is most enjoyable because it is become so easy now and so rewarding. The agenda that I mentioned is I'm going to talk about what is neurosurgery, why one would like to do neurosurgery, and how one can do neurosurgery. So first of all, I want to remove a myth that neurosurgery is not only brain. Though we would like to be called ourselves as brain surgeons, it is not only neurosurgery, is not brain surgery. It includes the central nervous system as well as peripheral nervous system. And the another interesting thing, as we divide in UK as elective, that means planned, and non-elective, that means unplanned, unscheduled. And 2/3 of our work is unscheduled. That means I do not know what I'm going to do tomorrow or day after when I'm on call, because we don't plan what comes through the emergency through the door. And more importantly, this is the most important thing, as against many other surgical specialties, 2/3 of our work is unplanned. This is a photograph from a local newspaper, and you can see a metal object in someone's skull, and as it is written, this patient was saved from poor outcome. He was a Polish young gentleman who had some fight with a flatmate in the morning during breakfast, and this butter knife was pushed through the face, very close to the eye or the bridge of the nose. And there are anatomical reasons why this is possible. Even though the knife is blunt, how can it go right up to the head in the brain? But we don't have time enough to discuss that. But you can see the plain X-rays and the CT scan, which you can see. I don't know whether you are able to see my cursor, but there is a metal artifact. So in the CT scan, the metal is shown as dark, and therefore you can't see what is here. But on the first scan, you can see that there was little blood speck, and then this is further lower scan. Now I did further CT scan called CT angiogram to understand the blood vessels before removing this. This was removed uneventfully, and this is the post-op scan with no metal but little bit of blood, and patient recovered very well, and I would say he was lucky rather than I was smart. On the other extreme, I have been to New Zealand for a year, and I treated this patient, 43-year-old man with a seizure, epileptic fits. And the neurologist investigated with an MRI scan where a blood vessel abnormality was seen here, and this is an angiogram. And the modern way to do the 3D angiogram shows a blood vessel abnormality known as AVM, arteriovenous malformation. This is per operative picture through the microscope when we are opening the brain and taking this AVM out. The modern science allows us to use further technique, and we can do this sort of angiogram with a fluorescent material during operation. So this is a picture taken through the microscope. You can see the original picture in the inlet view here, and this was a dye known as ICG, which is also used many times by ophthalmologists to look at the back of the eye. And there are other similar dyes also, so you can confirm again on table when the brain is exposed. The same sort of picture what you are seeing, you can see this loop here, the same loop is seen here, and this was the blood vessel abnormality known as AVM, and then it was removed. So you can see we have been into the brain and removed this abnormality. And this is another angiogram we have taken following the operation. The abnormality was removed, and we confirmed that everything abnormal has been removed. This is possible with the modern technology. So science has progressed a lot, and therefore I am going to say that why choose neurosurgery? Of course, because it makes sense. And it is how you see yourself. The advantages of neurosurgical training and practice are, it is in the forefront of medical and surgical advances with high-end technology, which we will discuss in a minute. You can improve patients' quality of life. You get to see variety and interesting patients and disease processes. There are still some diagnostic challenges. However, in Britain currently, the training is run through. That means for 8 years, once you enter the neurosurgical training, it continues for 8 years, and at the end, you normally are expected to be a faculty. The first and foremost gadget that we use is operating microscope. This was introduced initially by ENT surgeons. We neurosurgeons, and the father of modern neurosurgery, who is still alive and 95 plus, Ghazi Yazargil, a Turkish neurosurgeon who practiced all his life in Zurich initially, then another 20 years in US, and for last few years he has returned to his home country of Turkey. He introduced use of microscope in routine neurosurgical practice in mid-60s, and we currently operate every condition practically with the use of microscope. And I would say, if there was one important gadget on one major change in our practice, that is through the introduction of microscope. We also have such sophisticated machines called CUSA, which is a short form of cavitron ultrasonic surgical aspirator, and that is a very sophisticated suction machine which takes away the tumor without disturbing the brain or important surrounding structures. And of course, the last but not the least is navigation. Like in most of the cars these days, you have got navigation. Same way, currently in neurosurgery also we use navigation to be precise in opening the head or spine. The disadvantages of neurosurgery are that the duties are very onerous when you are training. The units are far apart. In a small country like this also, it is not easy. In the larger cities they are usually, so for example, neurosurgery in India also, when I trained in late 80s, it was only possible in bigger cities and not in smaller cities. And the patient load is constant, and in Britain particularly, there is a lot of pressure on bed availability that you may be reading in the media. Am I going at the right speed, Ashwini and team?
Yes, doctor, it is fine.
Thank you.
It's very interesting. The slides are really, really very nice.
Thank you. So when I trained, neurosurgery itself was a specialty that was largely evolved. But over the period of last 30-40 years, the neurosurgery has been subspecialized, and these are the 7 very well established subspecialization currently, and I will go through each one with an example or two. So in pediatric neurosurgery, you see normally hydrocephalus. You can see a young baby with a large head and enlarged scalp veins, and you can also see something else like this, another young boy who has got this arachnoid cyst, which is like a localization of the CSF, but you can see he was born with this, so the temporal bone is prominent, and you can see the same thing here on the left side of his face. These are all pediatric neurosurgery cases, and then some children have also what we call spinal dysraphism, which is a big group, but this particular condition is known as lipomyelomenigosil. You can also have some horn like this, what you are seeing, or some dimple, but a big lump of fat, etc. So these are all very interesting conditions. We don't have enough time to go through the details of that. Then the biggest currently evolved subspecialty is spine surgery. This is a junctional area where neurosurgeons and orthopedic surgeons both meet, and sometimes they work jointly, which is a fantastic, I would say, evolution. But usually we come across such degenerative conditions that you might have heard: slip disc or sciatica in the lumbar spine, as you can see here. It also includes some spinal tumors, as you can see. If you are able to see my cursor, there is a tumor behind the C3 vertebra here. This is a spinal cord which is deformed by the tumor, as you can see here. And this is a per-operative picture, the spinal cord with the nerve root, as you can see here. And the tumor is seen here. So the tumor is in front of the spinal cord, and the spinal cord is wrapped around this, which was taken out through the microscope. That picture was through microscope, and you can see the tumor has gone and the spinal cord has come to its original position. Patient presented with quadruparesis, paralysis of all 4 limbs, unable to walk, and went home walking. So this is very rewarding and satisfying outcome. Then comes the skull-based surgery, which is currently perhaps the most challenging conditions, because there are lots of important neurovascular structures at the base of the skull, and it includes something known as vestibular schwannoma, tumor arising from the 8th cranial nerve, where patients present with deafness and tinnitus. And to take this tumor out, is a very challenging undertaking. In vascular neurosurgery, as I already showed you the example of AVM, arteriovenous malformation, that was excised microsurgically. So we also nowadays, this is a 180-degree change in the management of aneurysms, which is the commonest vascular condition we treat. This is an angiogram of a basilar tip aneurysm, which in my training time was one of the most difficult surgical exercise. But these days, with the evolution, we do not need to operate on these patients. We can treat them endovascularly by deploying coils through this same route, and this has revolutionized the treatment of aneurysms. What has changed is that in my time, we used to do a carotid artery puncture with a big spinal lumbar puncture needle into the neck and run the dye. Nowadays, we can do that with just intravenous injection of the dye, and you can see these beautiful pictures, the 3D reconstruction. You can see the left middle cerebral artery aneurysm that you can see. You can have a 3D reconstruction, and you can also have this sort of software programs. And if I show you in the new version, you can also see this as if you are looking inside the patient's head, and this aneurysm is seen on the left side. And we can also have various computer programs where we can remove the bone, we can plan operation. It is known as simulation, and that is very, very important tool in the current practice. On the other hand, this was a recent patient I treated, a 17-year-old man who presented with headache, and this is the CT angiogram that I am showing you in the 3D reconstruction. You can see a big arteriovenous malformation. This was occupying almost all of his right occipital lobe. Now the only problem is that if we were to treat it by any means, mostly surgical, he would end up being blind in that field of vision, and therefore we suggested to not go into treating him because he did not have any major problem except headache. And that brings me to an humble prayer that you might have heard: "Oh, grant God me the serenity to accept the things I cannot change." That means I cannot change the outcome of this patient. Courage to change the things I can. Many patients' life I can change, but most importantly, the wisdom to differentiate the two. And I am going to bring back this wisdom towards the end of my presentation. This is a very important prayer I learned when I was a surgical trainee in Baroda, and Tata Memorial Hospital director, Dr. P.M. Desai, had presented his series of work and taught this dictum. The neuro-oncology is a specialty dealing with brain tumors, and there are significant advances in that. So this is a young lady. You can see this is her eye on the top of the eyebrow with a very small incision. I know this picture is not very well seen, but just roughly a 2-pound coin opening was made to remove the brain tumor. She had a metastasis from the breast cancer, and you can see this was the immediate post-op when I had taken subcuticular stitches. So this is possible with the navigation that I mentioned, because we can be so precise that through a small opening we can remove the tumors without opening the head completely or disfiguring someone's face. This is the latest advance in imaging known as diffusion tensor imaging. You may know from your anatomical teachings that the brain has grey matter and white matter. When I was a student, our understanding was that grey matter is more important, and that is still being taught world over. But now we have learnt that white matter is even more important in some of the brain tumor operations, and therefore the MRI allows us to study the white matter. As you can see, what different color the tracts. This is the corona radiata and corticospinal tract, starting from the motor strip, going down through the internal capsule into the spinal cord, and these are other white fibers known as arcuate fasciculus, and these are known as inferior fronto-occipital fasciculus. You don't need to worry about all these. What I'm trying to show is that we want to understand whether this is, as you can see, there was a tumor here, whether it is displaced, as you can see it is moved away, or whether it is infiltrated, and therefore we can decide how much tumor we can remove and whether it will cause the harm or not. Secondly, this is another advance in